Assalamualaikum and good day. My name is Putri Ifaridina binti Idrus Shahril. I'm from the Bachelor of Medical Imaging from class cohort 12A. Today, I will be presenting about the corticospinal tract. So, these are the contents that I will share to you in our video today. So, we have the introduction to the descending tract, the corticospinal tract, the causes in the corticospinal tract, the summary, function, and lastly we have the clinical significance. So, first we're going to look into the introduction to the descending tract. So, we have our CNS, central nervous system. So, the central nervous system have this descending tract, which are the pathway by which the motor signal are sent from the brain to the lower motor neurons. So the lower motor neuron directly innervate muscle to produce movement. So the motor tracts can be divided into two. We have pyramidal tract and extrapyramidal tract. So this pyramidal tract originates in the cerebral cortex, carrying the motor fiber to the spinal cord and brainstem. They are responsible for the voluntary control of the musculature of the body and face, while the extrapyramidal tract originates in the brainstem, carrying motor fiber to the spinal cord. So, responsible for the automatic control of the musculature such as muscle tone, balance, posture, and locomotion. So, these are the differences between the pyramidal tract and extrapyramidal tract. So, we're going to look into the pyramidal tract. So, pyramidal tract is a group of corticospinal fibers which occupy the pyramids of medulla oblongata. So the tract is the longest tract, starting from the motor cortex to the last segment of the spinal cord. So the pyramidal tract is voluntary motor pathway. Next, we have the pyramidal fibers. 55% of the pyramidal fibers end in the cervical, 20% in the thoracic, while 25% in the lumboscacal region. So the pyramidal tract is divided into two. We have the corticospinal tract and the corticobular tract. So corticospinal tract. Again, the corticospinal tract are not the sole pathway for serving voluntary movement. They form pathway to confer speed and agility to voluntary movement and use in a performing rapid skilled movement. So this is the overview of the pathway for the corticospinal tract. So the corticospinal tract, or we can say CST, are the pathway concerned in the voluntary discrete skilled movement, especially those of the distal part of the limb. So we have white matter. So what is the white matter? The white matter of the spinal cord is arranged in three columns or tracts. We have the anterior, the posterior, and the lateral. So these tracts are formed by sensory nerve fibers ascending to the brain, motor nerve fibers descending from the brain, and the fibers of connector neurons. So this is the spinal cord anatomy. So we can see the yellow one is the white matter, while this is the ventral horn of gray matter, and this is the dorsal horn of the gray matter. Okay, so it's important for us to remember this because this will use in the corticospinal tract. So, corticospinal tract, we have the lateral and the anterior. So, for the lateral, the fibers within the lateral corticospinal tract discussate, which means cross over to another side of the CNS, the central nervous system. So, then they descend into the spinal cord, terminating in the ventral horn at all segmental levels. From the ventral horn, the lower motor neurons go on to supply the muscles of the body. So, for the anterior part, the anterior corticospinal tract remains ipsilateral, descending into the spinal cord. Then they discussate and terminate in the ventral horn of the cervical and upper thoracic segmental levels. So that's the difference. Okay. The lateral corticospinal cord terminating in the ventral horn at all segmental levels, while the anterior terminate in the cervical and upper thoracic segmental level. So the corticospinal tract begins in the cerebral cortex, which they receive a range of inputs. Okay, we have the primary motor cortex, which is the purple one. Then we have the premotor cortex, the blue, and lastly we have the supplementary motor area. Okay, now we're going to look into the causes in the corticospinal tract. Okay, so they're starting from the cortex. Okay, moving on to the internal capsule. This is the internal capsule. Midbrain, through the basis pendiculi, pons, medulla oblongata, and then from here they will separate into the lateral corticospinal tract, anterior corticospinal tract, to the motor neuron, and lastly to the muscle. So we're going to look into the cortex and the internal capsule. So what happened here? So in this region, this is the motor area of the cortex. So what happened is that originating from the cortex, the neuron converge into the corona radiata and descend through the internal capsule. So this here is the internal capsules, a white matter pathway located between the thalamus and the basal ganglia. So in the internal capsule, the fibers then pass through the posterior limb of the internal capsule, where they are organized in the sequence fiber of upper extremity, trunk, and lower extremity. So here, especially at the internal capsule, we have a clinical significance, which is known as a capsular stroke. So this event could be cause a lesion of the descending tract. So next, we're going to look into the midbrain and pons. So this part is the midbrain, and during midbrain, the tract then continues through the crus cerebri of the cerebral peduncles or basis pendiculi here of the midbrain ventral to the substantia nigra. So it will move down to pons. So it passed through the basilar part of the pons. In the pons, the corticospinal tract became scattered. Okay, it started to scatter. So it will go down to the medulla oblongata. So what happened here? So while coming out from the pons, the scattered corticospinal fibers reunited and entered the medulla as a thick bundle. So the bundle become grouped together in the upper part of the medulla along the anterior border to form a swelling known as the pyramid or medulla oblongatory pyramids here. So the majority of the fibers will decussate into the opposite side, and enter the lateral white column as the lateral corticospinal tract of the spinal cord. So here is the decussation of the pyramidal tract occur. So it will cross, decussate into the opposite side. Okay. So the remaining fibers that do not decussate will enter the anterior white column as the anterior corticospinal tract. So the lateral corticospinal tract, the one that decussate. So in the lower part of medulla, the junction between the medulla oblongata and the spinal cord, the majority of the fibers, 75% to 90%, cross to the opposite side and descend in the spinal cord, occupying the posterior part of the lateral white column as a lateral corticospinal tract. So it extends throughout the spinal cord. At each segment, some fibers leave and the tract and turn inward and end round the anterior grey horn cell, either direction of the interneurons. So the lateral corticospinal tract descend in the lateral funiculus of the spinal cord to terminate mainly in the lumbosacral region of the spinal cord. Okay. So the anterior corticospinal tract. So, the anterior corticospinal tract, the remaining fibers, about 10 to 25% does not cross during the decussation and enter the anterior white column near the median fossa and descend down to the anterior corticospinal tract. So, the anterior corticospinal tract descend down the anterior funiculus and this of the spinal cord to terminate mainly in the anterior horn gray matter of the cervical and upper thoracic spinal cord levels. So near their termination, the fibers of the anterior corticospinal cord cross the midline to end round the anterior horn cell of the opposite side and instead synapse directly with the lower motor neuron. So we have the summary. So in the summary, I'm going to summarize the tract so it will become more understandable. So starting from the inputs we got from the premotor cortex, prefrontal cortex and supplemental area down to the corona radiata. So from the corona radiata, it will enter the internal capsule. So when the fibers are leaving the internal capsule, the fibers are scattered. So the scattered fibers will descend to the crus cerebri of the cerebri peduncle to the pontine nuclei. So the fibers will reunited when they want to enter the lower part of the medulla oblongata, which is the pyramidal discussation occurs. So when the pyramidal discussation occurs, the fibers are split into the lateral corticospinal tract and anterior corticospinal tract. So the fibers will descend down to the funiculus. So for the lateral part, it will descend to the lateral funiculus and vice versa for the anterior. So moving on, the lateral funiculus synapse the fibers synapse with the same side of the cell body of the ventral or anterior gray horn, while for the anterior funiculus synapse with the opposite side of the body. So that's a different, okay? So from there, it reached the alpha motor neuron and the gamma motor neuron. So for the alpha motor neuron, it stimulates the extrafusal fibers, which maintain the contraction, while the gamma motor neuron stimulate muscle spindles to maintain the length and the tone. So now, after we go into the pathway of the corticospinal tract, we're going to look into the function. What's the importance of the corticospinal tract? So they have many functions, which includes the control of the afferent inputs. Okay, so we all know the fiber originated from the sensory cortex, and then it will terminate in the dorsal horn of the spinal cord, and then they synapse with the interneuron that receive input from the somatosensory receptors and are taught to regulation information peripheral receptors within the spinal cord. Next is for the spinal reflexes. So the first order efferent sensory fibers transmitting sensory information, the muscle spindle, also from the synapse with the inhibitory interneurons, okay, which is the synapse with the lateral corticospinal tract to mediate reflex activity. So lastly, the function is for the motor neuron activity. It's divided into the lateral part and the anterior part. So for the lateral corticospinal tract, this mediate the execution of rapid, skilled and voluntary fine movement of the distal musculature of the upper and lower limb. So for example, the intrinsic and the extrinsic muscle of hand and foot, especially the muscle of the hand. So we can see our hand have a very fine and rapid and skilled movement, okay? So for the anterior part, it controls the axial muscle, which neck, shoulder and trunk, proximal upper limb, our girdle musculature, and they associated with the maintenance of the upright posture. So each of them have their specialty, have their own function. So lastly, we're going to look into the clinical significance. Type of lesions. So, what is lesion? Lesion is a region in an organ or tissue which has suffered damage through injury, such as wound, ulcer, and tumor. So, this resulting deficiency associated with the lesion to the respective tract will depend on the location of the lesion. So, where the injury is located. So, the injury to the corticospinal tract caudal to the decussation may present with varying types of paresis or paralysis of the upper and lower limb. So we have two types. We have the upper motor neuron lesion and the lower motor neuron lesion. So the pyramidal tract are susceptible to damage because they extend almost the whole length of the CNS. Okay, so as mentioned previously, they're particularly vulnerable as they pass through the internal capsule. Okay, when the internal capsule, a common site of the cerebrovascular incident (CVA). Okay, the capsular stroke. So, if there only a unilateral lesion of the left and the right corticospinal tract, symptom will appear on the contralateral side of the body. So, in addition, the lesion of the cortex or within the internal capsule may present with both corticospinal and cortibular findings. So, that is contralateral muscle weakens in addition to the cranial nerve abnormalities. So, we can see we have the cardiac sign of the upper motor neuron lesion. We have hypertonia. Hypertonia is an increase of muscle tone. Hyperreflexia, an increase of muscle reflex. We have clonus, voluntary rhythmic muscle contraction. And we have the Babinski sign, which is the extension of the hallux in response to the blunt stimulation of the sole of the foot. So when the Babinski reflex is present in a child older than 2 years old or even in an adult, is it often sign of the central nervous system disorder. And lastly, we have the muscle weakness. So we're going to look into each one of them. Okay, first we have the Babinski sign. So the normal response in an adult to stroking the sole of the foot is flexion to the big toe and often to the other toes, so following damage to descending upper motor neuron pathway. However, this stimulus elicits the extension of the big toe and fanning the other toes, so it's caused the similar response to the human infant before the maturation of the corticospinal pathway. Okay, by stroking of the sole of the foot, the big toe and often the other toe will flex. Next, we have the hypertonia, the hypertonia probably caused by the removal inhibitory influence exerted by the cortex. So, the hypertonia also eliminated by sectioning the dorsal root. So, the intensity of the hypertonia may vary markedly depending on the extent and the site of the central nervous system damage. So, here we can see a person who is suffering from hypertonia. Next, we have the hyperreflexia. So, when the hypertonia is eliminated by the sectioning of the dorsal root, so this is suggesting that it represents an abnormal increase in the gain of the spinal cord reflex due to the lost descending inhibition. So, it will cause the hyperreflexia. So, we can see here the patient is suffering from the hyperreflexia. So, next, we have the muscle weakness. So the weakness may range in severity from mild paralysis to total paralysis depending on the extent of the lesion. So these are the type of weakness or paralysis that we have. So when we have the injury from our spinal tract, so it will lose ability to perform fine movement. So specifically for the corticospinal tract, so if the lesion involved in the descending pathway that control our lower motor neurons to the upper limbs, so the ability to execute fine movements such as an independent movement of the fingers is lost. Okay. And lastly, we have the trisomy 18, the Edwards syndrome. So the condition that causes severe development delays due to extra chromosome 18. So they have 3 chromosomes in the chromosome number 18. So this exhibit various developmental abnormalities in the central nervous system. So we can detect this Edwards syndrome from their small head and jaw, their weak cry, and also clenched fist. So we have 6 type of six clinical significance from the damage of the corticospinal tract. So that's all I have. Thank you for listening and stay safe.